Hello and welcome to TEDx Gateways webinar series. The world has changed. TEDx Gateway is India's largest ideas platform and one of the largest in Asia after 10 years of putting together conferences on ground in Mumbai. And now we're, of course, coming to you digitally. This was created with an endeavor to bring experts, visionaries, and thought leaders across different fields to your home. Over the past 5 months, TEDx has brought engaging and thought-provoking ideas to more than 250,000 attendees in over 40,000 sessions. And I'm Govindraj Ethiraj, and I've been pleased to be part of some of these. The series that we are in today is called The Future of Healthcare, and it's presented by Abbott. And it aims to provide insights into the aspects of well-being, medical discoveries, and technological advances that are improving the quality of life. So now there are things that are moving a little too quickly. India now has the fastest number of cases of coronavirus, fastest growing number of cases of coronavirus for any country or in the world at over 75,000 cases a day. Now in March, remember when the lockdown was declared, this was the fourth week of March, we were looking at a few hundred cases a day, which progressed to a few thousand cases a day, but nowhere near the staggering number that we are seeing now. So today, India has about 3.5 million cases of coronavirus and about 62,000 deaths. The number of deaths is a little lower compared to other countries, but the trajectory of the deaths and the number of cases still continues to rise. And worryingly, cases are spreading out into the country as opposed to the original epicenters, which were cities, and within cities, some specific areas. So the big cities like Mumbai, Delhi, Bangalore are not so much the worry anymore. And surely not in Mumbai, where I am speaking to you first, or where my guest for today will be joining, which is New Delhi. So how bad is it? Is it really bad? Is it time for panic stations, or is it time for some calm, because we need to contextualize, we need to take a step back and look at things a little more carefully. So despite all of this, the number of, there has been limited epidemiological or clinical research in this subject and from this country. So today let's look at the largest study of the epidemiology of COVID-19 in the country based on data which is pretty extensive from the states of Andhra Pradesh and Tamil Nadu. And my guest, Ramanan Laxminarayan, will explain how India can use its localized data to better plan for intervention measures, as well as managing personal protective equipment, medicine, supplies for all, intensive care capacity, and healthcare personnel. So a little bit of background on Professor Ramanan Laxminarayan. He is the founder and director of the Center of Disease Dynamics, Economics and Policy, CDDEP, in Washington, D.C. and New Delhi, and a senior research scholar at Princeton University. He also chairs the board of GARDP, a global product development research partnership created by the World Health Organization that aims to develop and deliver new treatments for bacterial infections. He's also the founder and board chair at HealthCube, and which works to improve access to healthcare and diagnostics worldwide. Ramanan has a PhD and a master's in public health from the University of Washington. So on that note, before I hand over, do remember that this is an interactive session, and after he finishes his opening remarks, this is open to the floor. So I invite you to post your questions, and hopefully we'll be able to take as many of them as we can. On that note, now it's over to you, Professor Ramanan Laxminarayan.
Thank you so much, Govind. It's a pleasure to be back, and you know, it's a chance to sort of talk about both two things. One is, of course, pandemics as a whole, what brings us here, and the second is now to look at what the pandemic is doing in India now that we have some amount of data. You know, about 5 months ago, we were relying on projections based on evidence from other countries, but now we have the luxury of knowing what's going on in our own country. And then we can project forward to see what that means both for this pandemic as well as other pandemics. Now, just keep in mind that on any given day, there are 10 million people on an airplane going somewhere on the planet. And which means that disease is spreading from one place to the other extremely rapidly. Now, in the past, and this is a history that we are not familiar with, because this is, you know, many generations ago. You know, infectious diseases have been the biggest killers of humans, you know, equal and sometimes much greater than famine and war. You know, whether they were plagues or smallpox or, you know, flu, TB, syphilis, or, you know, Spanish flu, which again, you know, is the benchmark for us, 50 to 100 million people who died in 1918, 1919. at a time when the world's population was much smaller than where it is right now, and that 50 to 100 million people died, even though the flu actually only reached 25% of the world's population. And a lot of things have happened since then, which have made life better for us. Water sanitation, antibiotics, all of these have improved our chances of longevity. But as is clearly shown, this is always going to be a problem. So these are data that we don't have for India. But in the US, if you look at crude infectious disease mortality, proportion of people are dying of infectious diseases, and it starts at about 800 per 100,000 per year in 1900. And you notice that even before the first vaccine, which is applied at scale, which is for polio, that proportion has come down by almost 3/4. So much of what constitutes public health has nothing to do with doctors, has nothing to do with vaccines, nothing to do with antibiotics. It really has to do with water, sanitation, and hygiene. So, this is why things like Swachh Bharat are really quite so important. The second thing that you notice is this influenza pandemic, which really just takes off and creates this huge blip in the middle, and which shows that pandemics have, when they're compressed into short time scales, have managed to cause a significant amount of death. Now, you look at what the crude infectious mortality rate was in the US in 1942 when penicillin was first used. It was about 200 per 100,000 per year. Now, if you look at our current crude infectious disease mortality, is 2 times that of what it was in the US back in 1942, which means that there's a lot that we have to do as public health, which involves engineering, which involves logistics, it involves chlorination of water. These are the things that really bring infectious disease down at the grand scale of things, and they also help disease from spreading. So this is really where we're at compared to where even the US was quite some time back. And we also notice that once infectious diseases pop up in one place, and this is an example of resistance to chloroquine, which is an important drug that was used to treat malaria 50, 70 years ago, but today is virtually useless against the more lethal form of malaria nearly everywhere in the world. And this drug is chloroquine, of course. And 1957, 1959 were possibly when the first mutations arose, which conferred resistance to chloroquine, but they spread rapidly around the world. Within about 20, 30 years, they were everywhere. So today we can't use chloroquine anywhere for malaria, for falciparum malaria. Similarly, you look at strep pneumonia 23F. This is a very lethal strain of pneumococcal pneumonia, blamed on Spain, but probably started in France, just like the Spanish flu was blamed on Spain, probably started in the US. But anyway, the Spaniards get a lot of bad rap for a lot of things which they shouldn't. But then it spreads very quickly and becomes the predominant strain in the rest of the world. So I think the first lesson is to remember that this happens all the time. We are not immune to the rest of the world. What happens in one corner of the globe gets us really quickly. And I think it's time we really understood this interconnectedness that catches us. Now, I'm obviously here in New Delhi, and New Delhi metallo-beta-lactamase 1, which is a strain of bacteria, or rather, an enzyme, or mutation, which basically confers resistance to a wide range of antibiotics amongst gram-negative organisms. And that started in Delhi probably in the late 2000s and has now spread throughout the world. So this is, again, something which just in a period of about 5 to 6 years, it went from essentially 1 or 2 countries through most of the planet. So it can start anywhere and go everywhere. And if you look at COVID and you think, oh, well, this is happening after 100 years, not at all. Everyone remembers SARS, which happened in 2002, 2003, but we've had a number of emerging and re-emerging infectious disease outbreaks, whether Zika, cholera in Haiti and Zimbabwe, H1N1, which is a pandemic, same scale as what we have right now in terms of how fast it was spreading, probably spreading even faster than COVID. Chikungunya, Ebola, MERS, which started in 2012 or so. So we've seen this constantly, and even in very recent history, we tend to see this. And when we look back in time, we see that the number of EID stands for emerging infectious disease. The number of emerging infectious disease events has been going up over time. And this is both zoonotic, which means they come from animals, and also things which are non-zoonotic, which are the things in the black, which are mostly antibiotic resistance. And you can see that these events are going up all the time, possibly because of us encroaching on animals, us having a lot of animals, next to us. You have to remember that of the biomass of the planet, of all mammals, we make up about close to about 25 to 30% of the biomass, and the animals that we eat make up about 65 to 70% of the remaining biomass. And then very small amount, 5-7% is really all the tigers and lions and things like that out there. Most of the biomass is really on the planet of mammalian biomasses is mammals that we consume, and they all are capable of coming up with infections that could infect us. And the number of disease events has been all over the planet. You can see clusters, not because they're in Europe and North America, but that's because they have the best reporting systems there. But if you really look at the risk of zoonotic disease, it's concentrated in South and Southeast Asia. So we are a hotspot even for emergence of these events, just like China, because contrary to what many of us might believe, there's a lot of consumption of poultry and other animals in India growing at a rapid scale, just like happens in China and the rest of Southeast Asia. We were lower per capita consumers, but as this goes up, our consumption of meat is going up at such a scale that we are capable of breeding the same kind of infectious diseases, right here in our country. So it's not like these will always arrive from somewhere else. Now, obviously, we don't have these kind of wet markets where parts of animals, saliva, blood, mucus, fecal matter are all right next to live animals. We don't have an experience with this, but this is very common in in a Chinese wet market. And this is really the way in which pandemics mostly come. They come from pigs or bats or closely related species that carry viruses that are similar to what we would carry. And it just takes one person to bring the virus over, as we've seen in the case of COVID. And the spillover doesn't happen, just at one go. It comes from wild animals into domesticated animals, amplifies there, and then comes to humans. So we are right now, near some peak over here, but this virus has been hanging around for a long time. And unless we start looking for these over here, it's too late to catch it once it's just entered into humans. And again, our control is also not adequate to the task. So if we were smart about future pandemics, we should not be looking just on day 42, hypothetically, for when it comes into humans. We should be looking much earlier at what they are in animals, look at when they jump into domestic animals, and then when they come to human cases, we should be absolutely ready for them. We are just not ready with that kind of a system in most parts of the world. Now, I want to jump very quickly to a completely different scenario, which is now what is going on in COVID in India, and run you through some data. These are possibly the largest, single data set aggregated from Andhra Pradesh and Telangana and Tamil Nadu, thanks to the governments of both states, which have been very generous with sharing these data, which have enabled the largest study of this kind, not just in India, not just in the developing world, but really in the world per se. So this is a data set which covers something like 80,000 primary high-risk cases, and then 550,000 contacts of these cases. So I'm going to walk you through what's a really rich, understanding of what's going on in these two states. And let me also tell you that this paper is online at medRxiv. It's a slightly earlier version of the paper, so these have changed a little bit because they've been updated, but by and large, the story is exactly the same. So you can see the incidence has been changing over time. Now we know that it's been mostly focused in Tamil Nadu, in the districts around Chennai. So Chennai is right out here, and Chennai, Kanchipuram, and Tiruvallur are considered essentially one large urban area. And in Andhra Pradesh, it's around Krishna, Guntur, and Kurnool. These are places which have a lot of the COVID cases. Now, as you progress forward, you then see that the reds start lighting up, which means that you have Virudhunagar and Kanyakumari and Coimbatore and Nilgiris also now catching up with cases, and which were not the case. And Kurnool is, of course, the place where you have the most, and of course, Visakhapatnam and Vijayanagaram. So it does spread, and you can see that very clearly in this. And daily caseload, again, we're seeing this every day because there's also a huge testing ramp up that has happened in the two states. And here is the daily cases. This is the test. Now, today, Andhra Pradesh and Tamil Nadu do as many tests on a per capita basis as many developed countries do. So although India tests low as a whole, these two states are testing at a huge amount, and they spend a lot of money on their testing as well. And you can see that in spite of that, the positivity rate, which peaked after March 22nd, which was really the time when the lockdown was put in place. And remember, everything happens with the 2-week lag when it comes to infectious diseases. Then it started going up again, and the blue, again, to remind you, is Tamil Nadu, and sort of the purple or violet is Andhra Pradesh. And these are the daily death counts as well, where Tamil Nadu had an earlier epidemic, and AP is also caught up over time. Now, cumulative incidence and mortality over time has also been climbing, again, over this period that we've had the data. This is events per 10,000. And let me unpack this a little bit for you. So first, let's start with contacts. Now, again, let me just say that parts of these have been reported by other researchers, and both in India and other parts of the world. So it is not as if these findings are absolutely novel from understanding the disease. So I don't mean to say that at all, but just to say that this is what we found in this data set. What we found in these data, and you can see these are very large numbers of secondary contacts of primary cases. And you can see that if you look at this slide, the index case percentile. So up to about 68%, those cases are not generating any infected contacts. But then when you start going up very rapidly from here, so once you get to about something like 92% account for 40% probability of a secondary case, and by the time you get 100%, then obviously you get all of your positive secondary cases. So you see what looks like super spreading, in the sense that small proportion of the primary cases are responsible for a lot of the secondary cases. So it's not like everyone is uniformly infectious the same way. Now, obviously, this is mediated by behavior and other factors, so it's not purely biological phenomenon, because one person who's able to sneeze in a large crowd obviously has a very different impact on transmission than someone else. But even so, we do see evidence of super spreading, as has been reported before. Now, we did have data on whether people were high risk or low risk contacts based on, that was reported. And what we interestingly found was that there wasn't a huge amount of difference in the risk of male to male or male to female contacts from the other two. Female to male or female to female seems slightly higher than female to male. Again, could possibly be explained by contact within the household, and within low risk contacts, those seem all, the probability of positive contact seems to, all overlap quite a bit. Now, this is a very interesting finding, which is about case and contact age. So on the x-axis is, the contacts, from age 0 to 4, and then the positivity rate by age, sorry. So the x-axis is the age. And you can see that kids transmit most to kids, whether they're high risk or low risk contacts. Those in the 5 to 9 age group transmit a lot to that age group. 10 to 14 transmit to that age group. So you're seeing, and of course, if you go to the 80-plus-year-old, the 80-plus-year-olds are also transmitting a lot to that age group. Now, we've always wondered, are people transmitting within the household, like kids are transmitting to the elderly to kids and so forth? We don't find evidence of that. What we see is a lot of evidence of age cohorting and transmission, which again was something that surprised us, because our sort of generic understanding of Indian households is that everyone is coming in contact with people of a different age, and that's the primary contact, but turns out to not be the case. Now, this is a slightly more complex slide, but I'll just walk you through it. And these are transmission probabilities by age given an exposure. So given that you're exposed, what is your transmission probability? Now you can see that this is the index age, case age, and this is the and this is the contact age, and you can see a strong 45-degree lighting up of the red. What that really means is, again, this contact age, that the index case age and the contact age are highly correlated, which means that kids are doing a really good job and very effective job transmitting to other children. In fact, we see a lot more of the child-to-child transmission than anywhere else. And this has been a question which has not really been addressed in many other countries in terms of what the role is of kids in transmission. And what we see from these data is that kids are doing a fabulous job transmitting within themselves. They're also doing a reasonably good job transmitting to other age groups, but they are a major driver of transmission, which will have implications for whether we want to reopen schools and things of that nature. Now, keep in mind that we are not adjusting for things like duration of contact. So we're just saying, did you come in contact with? Now, it is possible that when children play together, they hug, they don't maintain any sort of social distance, whereas adults might actually do that. But even so, you see that all ages are transmitting primarily to their own age groups. Now, if you look again then at the predictors of time to death, which is the second piece of information that we had, and we see that the predictors of time to death are first and foremost its age. So obviously the elderly population is very fast in terms of time to death. The hazard ratio is really the highest. And we also see that males are at higher risk. And the interesting thing is we see that by date of testing, and these are month-wise clusters, that the time to death has actually been decreasing. Now, I was speaking to an emergency care doctor, a critical care doctor down in Chennai earlier today. And he was saying that the guidelines and the quality of care that they're able to provide today are much better than what was possible maybe 3 or 4 months ago, because their understanding of the epidemic is far better. And he thinks that half of severe cases today, they can recover, whereas that was not the case in the early stages of the epidemic. So I think that is truly a positive as far as the epidemic is going, which is the doctors understand what to do if you're a severe case and have a much better chance of getting us back on our feet compared to what we had before. Now, of course, predictors of time to death, Tamil Nadu has a slightly higher risk of dying, but it's not, it's about an 8% amount. Now, if you look at case fatality ratios, now again, everyone has been talking about case fatality ratios, and I'm not going to get into the, this is just based on the reported cases as per the testing and the proportion that died. Now, there are many things that you can say, well, deaths are undercounted, tests are undercounted, all of the stuff. This just takes away from that. This just says, this is the people that we followed, and then we saw if they died. That's all it is. And you can see that the proportions, all cases, is very similar, maybe slightly less than what you see in other countries. But that 16% really jumps out at me because that is actually quite similar to what we see in the Chinese studies, which is the 16% mortality, the case fatality rate in the elderly 85 plus population. Now they had it at a slightly earlier age, but still this is quite consistent with what's happening in the rest of the world. So this again is based on something like about 7,000 deaths overall. So it gives you some indication of the size of the data set we're going with. And of course, as we know quite well, it's about 1 in 5 for males, and it's only about 1 in 10 or less, or slightly more than that in the case of females, for the 85 plus population. But interestingly, you see that the ratio is not small for the 50 plus population. It's still about 3.8, almost 4, and above 4 if you're a male. And so the case fatality ratio does seem to jump up quite a bit, going from above 40 into the 50s and 60s. So again, a variation that we see in other countries. Now this is called survival curve. So basically it's to say on day X, so day 10, what proportion are still surviving? And these are all age groups. So obviously the lower the age group, you'll expect them to mostly survive, and the oldest age group to do a better job at survival. And we can see that, there's a whole cluster of deaths that happen. So if you look at the above 85 category, for instance, about half the deaths are happening by day 7 itself. And then the remaining deaths happen through to age 30. Similarly, you look at the male population, you can see that by day 8 or so, you've got half the deaths down to 90, and then the remaining survival probability, it's all the way down to day 30. So it's clear that there's sort of an early chance of dying and then a later chance of dying. And this is the population age distribution of India, or these two states compared to the US, for instance. The US is just a random comparator, because we have a lot of data from there as well. You can see that our age structure is such that the Americans are slightly older, and we're a slightly younger population. But the difference is not as great as we had compared it, say, to Europe, for instance. But if you look at the case age distribution, you see that the US has far more cases in the older category than we do. And if you look at the death age distribution, it's vastly different. We have a lot more deaths in this 50 to 64, 65 to 74 age group compared to the rest. Remember, we're adjusting for the population age distribution, so we're showing you what that is up here. But you still see that compared to these other, compared to this one other country, that we seem to have deaths at a younger age. So this is again, of some interest and concern. Now, finally, when you look at testing dates, this is a number that a variable that most people have now gotten very familiar with, called the reproductive number. Reproductive number, again, for your reminders, it's a number of secondary cases that is generated in a completely naive population when you have the first infected case. And the effective reproductive number is effectively, coming up with that sense of how easily that virus transmits at different points in time. The reproductive number is obviously influenced by our social distancing, our mask wearing, and all of this. And you can see that the lockdown period did have quite an impact in knocking down, and this is the first, the first lockdown period, the 3-week lockdown, that it really knocked down the epidemic curve significantly in Andhra Pradesh, for instance. In Tamil Nadu, it didn't quite have that effect. It still went back up, but then, both these states have had sort of periodic local lockdowns. But that said, you can see that the reproductive number in these two states is still much lower than what it was at the start of the epidemic back in March. And if we had continued at the March trajectory without these lockdowns, we would have been in a very different position than where we are today, for a range of reasons. We would have had a huge epidemic wave way early in May, and we also would not have had the clinical experience to be able to reduce mortality like we now have. So that is about that study. But let me go back to what we think about when we prepare for pandemics. Now, this is a cover story that I wrote for the Milken Review back in 2017. And, we've been writing about this issue for many, many years. And I think we're all focused on the here and now, the vaccine. Are we going to have a vaccine? How do we really get out of this pandemic and so forth? But what I'd like you all to reflect on is that healthcare has a bigger purpose here. Healthcare has a purpose not just to be reactive, but really also to be proactive about what happens for the next pandemic. And I think healthcare is not just something which is done just by doctors. It is something which is done by many people, including politicians. It's done by many other folks who have to think about what happens next. And if you really think about what's going to happen next, all of our experience from the past indicates that you don't have to have millions or even hundreds of thousands of lives to shut down international commerce. You can imagine that even if we're done with COVID, the next pandemic, whenever it occurs, it could be in 5 years from now, it could be 3 years from now, it could be in 200 years from now. We don't really know. But it's quite likely that something will come up in the next 5 to 10 years, that these have the same potential to inflict significant damage on the global economy because of the uncertainty that it brings. We really don't know what the effect is or what a new virus is going to do. And to be perfectly honest, we don't know what this virus itself is going to do. We know a lot more about it 6 months into the virus, 7 months into knowing what the virus is since it arrived in India. But we still don't know, whether people can get reinfected. We don't know how much immunity they can gain. We don't know if we'll have a vaccine. We don't know if we have any treatments. So there's a lot of uncertainty here. So I'd lay out, 3 things that healthcare really should be aware of. First of all is that I think we need to invest far more in systems to be able to respond to these sorts of outbreaks, which are in the form of early detection and response. And this has to do with, health as a whole, which is, unless we have the ability to contact tracing, screening people, rapid diagnostics, all of these are important for us to be able to figure out when other outbreaks do actually happen. And I think as a consequence of COVID, a lot more people are now aware of how microbiology is actually really quite important. I think the second is to realize that, and this is something that we've seen in the past as well, that the course of any disease outbreak is a bit endogenous because, and what I mean by that is our behavior is a single most important factor that determines how these outbreaks sort of evolve. That explains the difference between why India has not been able to shut down COVID, whereas many other countries which are not wealthier than us, whether it's Vietnam or Thailand or Malaysia or in Africa as well, seem to have done a better job than us in terms of being able to shut things down. And I think here behavior is important. The population understanding of health is going to be really important, and we've not spent or invested really enough time in doing that. And I think the third part of this is really to do with technology. And I think technology is obviously going to offer a very different pathway to healthcare, whether through telemedicine or consultations. But I also think technology is going to play an important role in early detection of outbreaks, which are that we really need to have, similar to a weather warning system, that we need to have sensors all over the country which are picking up clusters of normal pneumonia cases. We need to have these connected around the world, and I think this is a global challenge in that sense. One of the tragedies of COVID, I think, is that the world has not really worked together very much at all, whether on a vaccine or anything else, to really come together to try to solve it. It's almost like every country for itself. Do you have your vaccine book? Do I have my vaccine book? That kind of a story. And I think investing in entities like the World Health Organization, which get a pittance compared to the role that they play, is really important. No question that they should be revamped and reinvigorated and probably made to be a lot more effective than they are right now. A lot of criticism of WHO is perfectly valid, and I serve on many of these committees at WHO, and you see that they could be a much better organization. But I think we need to, coming back to my first slide, we need to understand that we are not in this as a single country by itself dealing with these things. Unless we play a bigger role in shaping our future at these international organizations and agencies and are part of that global science and response system, we are not going to be first in line in order to understand what's going on or in being able to tackle these epidemics. So with that, I'll stop here and turn back to Govind. Thank you.
Thank you, Professor. So I think it's a very interesting and insightful set of points, and the focus on the non-medical response, the focus on preparedness, the focus on understanding this better, which we do. So let me ask you a very broad question first, because before we dive into some of the points that you've raised from your study as well. So the curves are still rising. I mean, when you look at, when you step back, you look at the number of deaths, you look at the number of cases in the country are continuing to rise, wherever they may happen. And it may be true that in some parts of the country, they're going down or being better managed. What is this telling us from, in terms of our ability to forecast the life cycle of this disease at this point?
It's a really tough question to answer, simply because the response, like I said, this again goes back to my first point, the response is completely different, and the reactive lockdowns going on throughout the country. So it is, it's almost like something happens and people put a brake on it, then it starts climbing and then people put a brake on it. So looking forward, the only certainties we have are the same certainties that we had back in March. One is everyone is susceptible until they've had an infection, and even then we don't know for how long. That's number one. And number two, the reality is we have a large country. Those are the two ground truths here. So when you look at those two ground truths and you say a lot of our population is still uninfected, and a lot of them are in rural areas, they're in places without healthcare facilities, I think we still have some ways to go. We might not necessarily visually see this in the way that we saw it in Delhi or Mumbai or Chennai, but that pain of the disease is going to continue because the disease is spreading all over the place.
And is there anything from the data that you've showed us, including of previous pandemics going back centuries, that it at some point it fades out? And if it faded out with much less medical intervention and systems intervention a few centuries ago, then is it likely to fade out in a similar time frame now?
It's interesting. We've not had an experience with, like 1918, for instance, was a flu pandemic. In other words, people who had been exposed to a milder form of that similar flu the previous season actually were not as badly infected. So it was actually a new strain, but of an influenza virus to which people had some prior experience. In that sense, we don't actually have an experience with a widely transmitted virus, which is just through respiratory contact. Really, in our sort of living memory, there's nobody who's around who's ever experienced that. So hypothetically, the cap for 1918 flu was not the entire world. It was always going to be something like 25% because a lot of people had been exposed before. Whereas hypothetically, the cap here is the entire planet until we get some sense of what we call herd immunity. That's why we're in a very different bucket now.
Right. And, you've been studying the spread of the pandemic or the likely spread of the pandemic in India as well. As days pass and the number of cases continue to rise, what's your assessment of the number of people infected now?
See, I think that based on, I'm just triangulating between seroprevalence studies and the infection rates and numbers of infections reported at that point in time. And depending on place and time, that ratio is, we're undercounting infections, true infections, by a factor of anywhere between 50 to 150, which means for every infection that's actually reported on the Johns Hopkins website or whatever, there are probably 50 to 150 underlying infections that are missing. So I would say, as a rough bet, there are probably about 200 million infections out there right now, which is, we have 2.5 million, 3 million cases or whatever. And then we're undercounting by a factor of about, I don't know, say 80 to 120. Right. It is definitely not 3 million infections right now. I hope everyone understands that.
Right. Okay. So let's talk about how it has spread. And you've emphasized a fair bit about the zoonotic nature of the source of the disease. So also, I think what you're highlighting is that it doesn't matter if you're in Italy or United Kingdom or United States. What matters is where it's coming from. And obviously, thanks to global travel, things will spread very quickly. So if we look at the source, and you also pointed out that even in India, and that's something that I know we've also studied at India's Pen, there are cases of, for instance, wet markets and potential sources. Though I think at this time, where most of the disease does seem to have emanated from China. But is that something that we can fundamentally change? Because you seem to be, in a way, making a case for, if I may put it differently, vegetarianism.
I'm not bringing a case of vegetarianism, but I'm certainly saying that meat eating at the scale that is happening on the planet does have environmental consequences. It has climate consequences, something like 1 in 6 tons of carbon emissions actually come from animals.
Right.
And it does have this disease consequence as well. It is like all other risks. So if you want to take on that risk, I'm not suggesting that people need, I'm vegetarian, but I'm not imposing that on anyone else. But I'll say two things. One is, I think that eating wild animals is probably a bad idea. I think that is universal anywhere, given the risk that you now pose to other people. So that's something which I would say really poses a high level risk. With respect to domesticated animals, I think that, in fact, the Chinese government is advising this, which is advising people to eat a little less meat. You don't have to eat meat at every single meal. I think meat plays an important role in people's diets without question, but we need to be mindful of the fact that there probably won't be enough meat for everybody to have meat,
right,
every day, twice a day, whatever else it is.
So you've also said that, we should catch it early and, catch it before it jumps to humans. And you've shown the graphs and you've showed why we are late now. And it's maybe 6 weeks or more or 8 weeks by the time we are even responding. So what can we specifically do there? I mean, from the lesson so far, if we can start acting even at this point?
So if people really remember, the Indian Council of Medical Research is actually set up to do exactly that, not to respond to outbreaks, which is actually the job of a different agency called the National Center for Disease Control. Now, ICMR has now taken over this role of responding to the outbreak, but ICMR's job is to actually help look for and predict and warn us about these outbreaks. We spend abysmally low on medical research. We spend something in the equivalent of, if I remember correctly, something like $200 million. Okay, this is, chump change for a country the size of India. So I think, given the size of our economy, where we stand in the world, the risks that are faced by our own, by our own people, we need to invest a lot more in that kind of research. Otherwise, we're going to face another Nipah virus outbreak, or Zika might show up, or whatever else it is. But I think that cadre of biomedical research just does not exist at the scale that a country of India's aspirations really deserves.
Right. And it's interesting because you mentioned, quoting your own article from 2017, that the United States spent $5.4 billion fighting Ebola, from which only one person or one American died. Now, so the money was spent and presumably a lot of preparedness happened, but that hasn't helped the United States, nor has it helped the world.
Well, in the case of the US, obviously, some things have changed since Ebola to now. They have a different president, so that makes a bit of a difference. But I think it's quite telling, right? So It is that they were willing to spend that kind of money to prevent this disease from entering the US. $5.5 billion. And the response in this time has been, so different. But it just goes to show that stamping something out very early. Now, if I had to, obviously it's hard to second guess, but I'm second guessing because these are things that I said and others said back in March. If we had tested at the rate of 200,000 tests a day back in March, we could have identified the hotspots of COVID in this country. We could have probably stamped out COVID in this country way early. And our lack of testing at the outset could not be compensated by the scale up of testing that has happened much more recently. So I think we did not use our own pandemic prepared plans. Now, since SARS, every country actually has a pandemic preparedness plan. I don't think we actually pulled out ours and said, what are we really supposed to do here? And I think that there are lessons to be learned here to say next time, let's do this very differently.
Right. So, Jyotika Singh asks, what do you have to say on the mitigation of this pandemic with the contribution of each country? So I'm assuming the question is to do with that we're all interlinked, and how do we each contribute in a way to solving the larger problem?
That's this stage. I think realistically, a vaccine is the only solution here. Now, we might get to a stage where, most people are infected and therefore have some level of immunity. And so we might end up in a different place. But that vaccine is really the only solution. But here, my plea would be, let's not screw it up. It is much better to get a right vaccine, which is safe and effective, trusted and widely available. All four of those things before we get it out there. Rather than rush to market with some vaccine that has not even gone through phase 3 trials and risk destroying people's confidence in vaccines. We're playing with people's expectations here, and we're telling them, look, we have a serious problem and a vaccine is what is going to save you. We cannot afford to put a vaccine out that has side effects or something that you discover will have some long-term health consequences 10, 15 years down.
Right.
We need a fast vaccine, but not at the cost of safety.
Right. Dr. Altaf Ahmed asks, to what extent is the research on epidemiology in India at par with the developed world?
Unfortunately, this is a place we've not spent much effort in training people. So this is naturally, we have we have a lot of the world's population. We don't have the epidemiologists to keep up with that quantity of people, and it is a skill that is sadly missing in the numbers that are needed in India. We need far more. Govind, I can't hear you. Hello? I'm not able to hear you. Okay. Yeah, Govind, I can hear you now. Sorry, I don't know what happened there.
Okay, just one moment. Right. Okay. So the question was, what do you make of modeling studies? And they've proved either they've underestimated or they've overestimated.
See, modeling studies, you have to understand what they were for. And I've also was the author of one of the earliest modeling studies here. Modeling studies are meant to give you a sense of what will happen if you do nothing. There is no modeling study that can tell you what will happen if you do various things, because how can I predict what all you will do? So the earliest modeling studies, and I would point to two of them, one by ICMR and one by our group, both came, gave some predictions back in March of what would happen by July, which was mostly that something like 20-25% of India could be infected if there was no response measure whatsoever. That is what the modeling studies said. Now, obviously, in response to the modeling, a lot of things happened, which is the lockdown happened in response to that modeling, various sorts of measures that were put in place in response to it. So naturally, the disease goes on a different, trajectory after that. But that doesn't take away the value of the modeling or of the intervention strategy. This is like a doctor telling you, if you don't lose weight, you will actually have a heart attack, by the age of 65. If you then decide to lose weight and you say, but I didn't die at the age of 65, that's a good thing, but it doesn't take away the value of that prediction, which I have to tell you, these are built on a lot of science. These are not just thrown off of people's head.
Right.
We
But yeah, so anyway, you're saying that they seem to have more or less rightly estimated, at least as from what we know today.
Well, today I'm telling you that we have probably about 200 million infections as far as the seroprevalence surveys go. You can take a range, say 100 to 300 million, because we really don't know. But that is in the range of what the models predicted. And that's in spite of having what is described as the harshest lockdown in the world. So
Right.
I don't think the modeling studies were off by very much at all.
Right. Ravi Shankar Venuturumilli asks, T lymphocytes are the deciding factor in long-term immunity. Is this true regarding SARS-CoV-2 RNA virus?
There's a lot that's been written about these T lymphocytes, and the fact that they might be this hidden, form of protection that we actually have. I don't think we know enough, and I think as a colleague, responded, it's a nice sounding story for something we would like to believe in, but we really don't have much evidence to really support it. So let's keep hoping whatever it is, but I don't think we've got the immunity related to SARS to COVID sorted out by a long shot.
Right. Okay. And I'm going to come to the Andhra Tamil Nadu study in a moment. Let me take another question. Shubhasri Srinivasan asked, is there a good method of data planning, collection and analysis that could be an adaptive template for rapid response teams?
We have one. It was put out by WHO after SARS, and India follows a version of it, which is run by the National Center for Disease Control. Our problem is that we don't provide the data back to researchers to study. And now we're happy to work with states which provide that data, but that system exists, by the way.
Ramesh Nandrajog asked, in a country like India, how reliable is the data collection, but especially from villages and particularly now, given factors like floods in many parts?
Great question. I would say India doesn't do that badly when it comes to data collection. With respect to things like contact tracing, all of these we've done well. The place we don't do well is really in mortality assessment. We don't assign a clinical cause of death, even in best of times, for 4 out of 5 deaths. And that's where we lose a lot of information about what is really afflicting people.
Right. So, let me come to that Andhra and Tamil Nadu thing. So one is, you said these are about 7,000 samples. And what would you say is the variation between what's happening in Andhra and TN, or has happened between other parts of the country? And particularly northern parts of the country, because your fertility and rates are quite different.
So 7,000 deaths, by the way. It's about almost 600,000.
Right.
Now, we haven't really compared it with the rest of the country because we don't have that kind of data for the rest of the country. We were only able to compare to the US because we have the data for the US. So I honestly don't know.
So what I mean is, for instance, let's say that more older people are dying, so you have a percentage. Let's say you have 20% for 85 plus. Would that be similar in many other parts of the country as well?
Govind, we don't have that data broken down at that granular scale. We have some things which come out in media here and there, but no data whatsoever.
Right. And, you also talked about the time to death, and you said that it's 7 days. Half the people have die within 7 days.
So in the elderly population, half die within the first 7-8 days, and then the remainder is from the 7-8 to the 30 days.
And do you know, or do you any insights on why this is happening?
We see this in other parts of the world as well, that a lot of people show up and then, in fact, within the first 72 hours, they're gone. And it's possibly because, they have a, severe respiratory distress that they came in with. It's also a function of when they were found to be needing hospitalization and when they actually came in. It points to a lot of people who are arriving possibly at hospitalization too late. The silent respiratory distress is possibly also behind it. So if we can push that window a little bit forward and bring people in a little earlier, we might be able to save some of these lives, would be my guess.
So Dr. Raj Pratim Sharma asked, can you elaborate on the role of people's sensitivity to the pandemic and the infrastructure required to control it?
So can you explain that question?
So I'm guessing what he's saying is that we have infrastructure, we keep building it. On the other hand, it's what if we have better resistance or less sensitivity to contraction and further deterioration? Is my sense.
I mean, I don't know. The only thing that was known to protect people is really these non-pharmaceutical interventions, which is mask wearing or social distancing. So I don't know if there's something different. We don't know if something gives you immunity against the virus, for instance. At least I'm not aware of it.
Right. Debadatta Mohanty asked, UK, Italy, and a few other European nations also suffered. They are developed nations with a much larger budget and on R&D as well as healthcare. Why couldn't they prevent? And this is a question that keeps coming up, Professor, as you know.
Well, it keeps coming up because I think we don't remember that we got the epidemic later than they did. So Italy got it, and they were caught on the upswing because they didn't even know that they had a pandemic. US was in a slightly better situation, but then they botched it up in a massive way. We were very lucky to have had time compared to those two other countries. So, but it also points to the fact that just having wealth alone is not a predictor of whether you can actually tackle a pandemic. You actually need public health and you need leadership. And that's what the lesson from the US really should be, that wealth doesn't protect you, investment in public health does.
Right. And we are coming to the end of our discussion in a few minutes, and we will come to that part about, what do we fundamentally do as a non-medical response, which you say is even more critical than the medical response. So, but before I come to that, Ajit Kumar asks, let me take this one. Ashish Kelkar asks, what is your opinion on the Swedish model of response to the pandemic?
The Swedes, you have to remember that people don't actually understand the Swedish model very well. The Swedish model was not that everyone is roaming around and interacting with each other. Swedes are very compliant. So if you suggest stay at home, they all stayed at home. The part where they didn't do as well was in preventing the disease from getting to their senior citizen and elderly homes, where it caused a lot of death and damage. So they had an idea of a policy, but I don't think it was implemented in a way that protected their elderly. And our lesson from there is let's keep a close eye on our elderly and reducing mortality.
Ajit Kumar asks, what are comparable mortality and morbidity rates for H1N1 in India, and hence are we overreacting to the COVID pandemic?
No, it's actually much lower. H1N1 was a more transmissible disease, but had a lower mortality rate. So I don't think we're overreacting. Let me put it this way. There are many things we could have done differently. If we had great data, we might not have had the need for the initial lockdown, for instance. So this is not to justify the way in which we approach the pandemic, but it is to justify the seriousness with which the pandemic has been taken in India, which I think is entirely appropriate.
Govindraj Ethiraj asked, sir, if elders are dying within 7 days of triage area, how can I predict which elders I should be taking care of? And is Tamil Nadu and AP doing anything correct to handle this situation?
So Tamil Nadu and AP, they do have an early reach out program. They do hand out pulse oximeters at wide scale. These are all quite helpful. They also, the big predictor is comorbidities. If you're able to tell who has diabetes, hypertension, particularly in India, we find in these data, and I didn't show that, something like 80% of people who die actually have these comorbidities. So it's a good predictor.
India has India has a crude death rate of 8 per 1,000 population, which is roughly 11 million a year. You'll have to fact check that if you can very quickly. How is this year's mortality compared to previous years? Essentially asking, are we seeing a scale of deaths which is way beyond what the normal number of deaths in a country, and therefore, I guess, relating to the intensity of the pandemic?
No, that's a very good point, by the way. So I think the actual number is about 8 million. I don't think it's 11 million, but I could be wrong as well. I think it's about 8 million deaths a year. But even so, the point is well taken, which is this really going to be such a massive blip on our overall mortality? It could have been if we had not responded. If there had been no lockdown, etc., that could have been the case. But I think that the response has been good, and that's held the mortality rate down significantly, which again is a point that deserves repeating.
Om Prakash HM asked, and I'm not fully got it, Ramanan, but if you do, please answer. I'm a clinician in private practice in Karnataka. We are reporting ILI and SARI cases daily to Karnataka government, but I don't benefit clinically. Can we expect more to help my patients? For me, patients matter, not statistics.
I think you make an extremely good point. This is a point that I try to make, which is that we have very little data transparency nationally on the COVID pandemic. The data is being sat on, it's not being released. I think with the researchers that we have and the data, we should be doing far more and in helping clinicians like the one who asked that question with evidence that helps them treat their patient. And I feel that the amount of clinical research and epidemiological research that has come out of India is not commensurate either with our capacity for that research or with the size of the country and the data sets we have.
Okay, there are many more questions. Some are fairly medical, so I'm leaving those out, Professor, and I'm sure that's not something you want to argue. So let's come back to the point that you made earlier, and which is the big takeaway, which is that if we focus on water, sanitation, and broadly health, we can perhaps fix this problem. And also, if we focus on the transmission, which is from animals to humans, and ensure that we respond faster, then we have a better chance. So do sum it up for us, Professor. How do we, one is acknowledge this and put more emphasis on this going forward?
I think that the main takeaway is that what is public health in times without the pandemic is good pandemic response. That is the sum of it, which means that if we're able to prevent infections from transmitting during normal times, whether it's tuberculosis or malaria or whatever else, then we will do far better during a pandemic. That investment requires to be, we, as a country, we don't understand public health. Public health has very little to do with medicine. Public health has to do with things like engineering, having clean sewers. Most of us don't know who the sanitation engineer is in our area. That person is the one who controls our lives and our destiny to a level that we don't actually understand. We don't give importance to the things that actually make a difference in our quality of life, which are all around things like water, sanitation, hygiene, things like air quality. That's really what makes our quality of life better. That's what makes developed countries what they are. That's what differentiates us from them. And I think it's time we took public health in that way really seriously. It is time for us to put the attention on reducing infectious diseases even during normal times. And if we did that, we would have a much better system to deal with the next pandemic when it rolls around.
Right, Professor. Thank you so much. I think this was a very, very insightful session. Thank you for putting together this study. Thank you for putting together a study in the context of what's been happening in the world for many centuries and allowing us to see a much broader picture, and also pointing to us some very, very simple and fundamental concepts about what it takes to keep a population healthy, and hint, it's not medicine all the time. So on that note, thank you very much for joining us. It's a goodbye from me and everyone at TEDx, and this was a series presented by Abbott, and we do of course hope to see you at the next Future of Healthcare webinar. And that's it from me once again. Thank you for watching and your questions, and see you soon.